Dr. Abdullah Kamal, and today we have three path level questions for Stepan and Lee. So let's get started. A 45-year-old immigrant recently diagnosed with tuberculosis started isoniazid therapy. He was presented to the ER with severe diarrhea. On examination, he was confused, dark skin around his neck. What the most likely diagnosis? So let's review B3 deficiency here. So first we have tryptophan. Tryptophan is a neutral amino acid, and it needs a very special transporter. That transporter transport neutral amino acids in both the gut and the kidney. Okay, so tryptophan can give B3, vitamin B3, which is called niacin as well, and B3 needs two vitamins, which is B6 and B2. And the way I remember it, if you 6 divided 2 equals 3, right? And tryptophan also give serotonin. And serotonin later on can be converted to melatonin, right? And we need two vitamins here as well, so we need B6 and BH4. Okay, so we have B3 deficiency. What are the causes or reasons for B3 deficiency? So let's go through it. First, it could be tryptophan deficiency, and actually that's a disease called Hartnup disease. So in Hartnup disease, you don't have that transporter that transport neutral amino acid, including tryptophan. And if you don't have that transporter, you wouldn't be able to absorb tryptophan from the gut, and you're gonna lose the tryptophan in the urine in the kidney, right? So in Hartnup disease, you don't have tryptophan, so you wouldn't have B3 or niacin, right? And that's the first reason. The second one is about B6. B6 deficiency is common in isoniazid therapy. And the isoniazid is antibacterial, usually used in tuberculosis. So isoniazid can lead to B6 deficiency, and B6 deficiency leads eventually to B3 deficiency. The third cause is about serotonin. We have carcinoid tumor. So in carcinoid tumor, basically it's a gut tumor, or it can be in the lung too. And carcinoid tumor produces huge amounts of serotonin. So what happens here is all tryptophan gets switched to this way to produce serotonin, and nothing will be left for the niacin. No tryptophan will be left for the niacin. So those are the three common causes of B3 deficiency, which is called the pellagra. Again, it could be in Hartnup disease. In Hartnup disease, you don't have the transporter to transport tryptophan, so you have tryptophan deficiency, which leads to B3 deficiency. First one. Second one is B6 deficiency, which is common with isoniazid therapy in treatment of tuberculosis. Third one is carcinoid tumor. In carcinoid tumor, you produce huge amounts of serotonin, so you get all the tryptophan to serotonin, and nothing will be left for the niacin. So pellagra, basically, it's 4Ds. 4Ds, it's diarrhea, dementia, dermatitis. And dermatitis, usually it's around C3, C4 dermatome, which is around the neck. And those three, if left untreated, are gonna lead to death, which is the fourth D. So if we get back to the case, you're gonna see like tuberculosis. Tuberculosis is common in immigrants to the US, and we treat tuberculosis with isoniazid. So isoniazid here caused B6 deficiency, which led to B3 deficiency, which is the pellagra. Okay. Second question. Second question reads, a 2-year-old female with a history of recurrent staph aureus abscesses. Her mother brought her to the clinic because of fever and cough for 2 days. A red pigment was isolated from her culture, and she started taking the right antibiotic. What is the most likely organism? Okay, so the diagnosis here, actually, it's chronic granulomatous disease. And let's review that pretty fast. We need to review respiratory burst. Okay, so respiratory burst, we have oxygen. Oxygen converts to superoxide, and superoxide converts to H2O2 or hydrogen peroxide. From oxygen to superoxide, we have NADPH oxidase enzyme. Then from oxygen to H2O2, we have superoxide dismutase. Then we have H2O2. How to get rid of H2O2? We convert it to water, okay? And depends if you are in human cell or bacterial cell. So if you are in human cell, H2O2 can be reduced to water using glutathione reductase. And glutathione reductase need to be reduced using NADPH. NADPH comes from HMP shunt using the enzyme G6PD, right? So G6PD is the main enzyme in the HMP shunts, which leads eventually to production of NADPH. NADPH reduces glutathione, and glutathione reduces H2O2 to water in the human body. In bacteria, it's kind of like different because H2O2 can be converted to water by an enzyme called catalase. Okay, catalase. After that, H2O2 can be used like as a toxic material against the bacteria. So basically, our body, it has myeloperoxidase enzyme, myeloperoxidase, and the myeloperoxidase, it puts chloride on the top of H2O2 and form HOCl, which is called bleach. Okay, so that's the normal pathway. So let's see some abnormalities. All right. So first of all, if you have NADPH oxidase deficiency, you're gonna get chronic granulomatous disease. And basically in chronic granulomatous disease, you get infections with catalase positive enzymes, catalase positive bacteria, which we'll discuss a little bit later, okay? Superoxide dismutase is another enzyme and it's deficient in amyotrophic lateral sclerosis, okay? After that, we have myeloperoxidase. Myeloperoxidase deficiency can lead to candidal infection. Okay? After that, we have G6PD deficiency or G6PD anemia. So in G6PD, we know like G6PD is the main enzyme in the HMP shunt which produces NADPH. So if we don't have that enzyme G6PD, NADPH wouldn't be produced, right? So if you don't have NADPH, you wouldn't be able to reduce glutathione, and if you cannot reduce glutathione, you wouldn't be able to reduce H2O2 as well. So H2O2 gonna accumulate inside the cell, okay, and it gonna denaturate proteins and make something called Heinz body. Heinz body is basically denaturated protein from the H2O2. Phagocytes recognize Heinz body and bite it just to get rid of it, and they give something called bite cell, which is basically like this, okay? So that's G6PD deficiency, okay? So let's get back to chronic granulomatous disease and let's do this. We have NADPH oxidase deficiency, between brackets, chronic granulomatous disease, and we have two types of organism, catalase negative and catalase positive. Okay, here we have H2O2. So let's put different scenarios here. So H2O2 can come from the oxygen through the respiratory burst, which we just like discussed. That's the first one or first source. The other source is from the bacteria itself, okay? And the H2O2, it can be neutralized or reduced to water in the bacteria using catalase enzyme, or it can convert to the bleach using myeloperoxidase enzyme, okay? So let's put two scenarios here. First one is the catalase negative. Imagine you have NADPH oxidase deficiency, so this pathway is gone forever, right? So normally you have two sources for the H2O2, oxygen through the oxygen burst and bacteria. But in NADPH oxidase patients, deficiency patients, they only have one source, which is from the bacteria, because this pathway doesn't exist anymore. So you only get H2O2 from bacteria. Okay, so if you catalase negative, you don't have the catalase enzyme to convert H2O2 into water. You don't have this, right? You don't have this equation. You only have this equation, right? So if you don't have catalase, you only go to the bleach. So this bacteria gonna die. Why? Because the bacteria gonna produce H2O2. H2O2 cannot be reduced to H2O because the bacteria doesn't have catalase. It's catalase negative. So it's gonna convert to bleach, and bleach gonna kill the bacteria, meaning there is no catalase negative organism infections in case of NADPH oxidase deficiency. Let's go to the second scenario, catalase positive enzyme. Catalase positive, again, we don't have the only source for H2O2 is only the bacteria, because it's only the bacteria because we don't have the enzyme, which is NADPH oxidase, to convert oxygen to H2O2. So we only have this pathway, right? So we have the bacteria producing H2O2, and if it's catalase positive, it already has the enzyme to convert H2O2 into H2O. Okay, so this bacteria wouldn't die because it's gonna convert H2O2, which is toxic, to H2O, which is not toxic. Okay, so those patients, NADPH oxidase deficiency patients or chronic granulomatous disease, gonna get a lot of catalase positive infections. Examples for catalase positive bacteria: Staph aureus. Okay, we have Aspergillus, we have Serratia. What else? We have Pseudomonas. We have Nocardia. Okay, so let's get back to the case. So here, you're all familiar with history, recurrent Staph aureus, so that's catalase positive. Okay, and we have another infection presented with fever and cough, and red pigment was isolated. Actually, red pigment is very characteristic for Serratia. Okay. Third question. 30-year-old nurse presented with low blood glucose. She was presented to the ER 3 times in the last year with similar presentation. Her labs show glucose level 4 milligrams, high insulin level, and no C-peptide. What is the most likely diagnosis? So here we have low glucose, high insulin, which makes sense because insulin decreases the blood glucose level, right? But the question here, the million-dollar question here, where does this insulin come from? Is it external or is it internal? What I mean by external is just insulin injections, okay? And that can be the case accidental. For example, in diabetes mellitus patients, they supposed to take 1 unit, they took 2 units. For example, they took more insulin than they supposed to take. Another example, it's insulin abuse. Insulin abuse. Insulin abuse is very common between healthcare workers, because you know, they have access to insulin because it needs prescription. Otherwise, normal people wouldn't have the access, right? So external in insulin abuse. So if you have high insulin, you're gonna get low glucose. Internally, there's two scenarios. First, B cell tumor. So B cell is a cell in pancreatic cells which produce insulin, right? And alpha cell produce glucagon. So we have B cell tumor secretes a lot of insulin, which gonna lower the glucose level. Another thing, sulfonylurea, which is anti-diabetic medication that helps to release more insulin from the B cell. Okay. So how to differentiate if this insulin coming from outside or from inside? From inside, it will has C-peptide attached to it, okay? So usually we measure the C-peptide level. If it's high, this means it's internal. If it's low or doesn't exist, then this means it's external. So here we have low glucose level because of the high insulin, and here we have no C-peptide, which means it's external insulin, right? Which of those? Diabetes? No. Diabetes, you're going to have hyperglycemia, not hypoglycemia. Pancreatic tumor, it could be pancreatic tumor if the question says high C peptide, but that's not the case. Alcohol abuse, no. Eating disorder, no. Insulin abuse, that's the right answer. Accidental injection of sulfonylurea, it's the same as pancreatic tumor. There will be high levels of C peptide. I hope you liked the video and thank you.